So my name is Brandy Klingman. I'm a licensed clinical social worker and a supervisor. I started out in my field just working individually with clients, seeing patients individually in a partial hospitalization program, and I loved it so much, but I quickly realized I really wanted to help more than just one person at a time. And I thought that there's a way to help more, and I loved group. I'm a member of a group association called American Group Psychotherapy Association, and I love that. So I just started more and more groups. And from there, I just started more and more programs. And so now I'm the owner of St. Christopher's Addiction Wellness, Legacy Behavioral Health, and LifeWorks Psychiatry, and a few other, Magnolia Springs, several little programs that I own and operate here in Louisiana. And I love what I do because I love helping groups of people and bringing us together. Just as what Ted was talking about, is the connection that's so important, is really a passion of mine. So I think that group therapy helps with that. St. Christopher's is an all-male treatment center here in Baton Rouge, Louisiana. And we help men who have been using substances or having dual diagnosis, mental health or substance abuse, for a period of time. I like to call our guys the knuckleheads, or the ones that are hard to reach. They've been in and out of programs a couple of times. They've had what their parents describe as like a failure to launch, although I don't use that term. I think it's a good example of where our mind was a few years ago about how we talked about these guys. So we help those guys. We bring them in. They stay with us on long-term level of care. So we bring in from detox all the way out to IOP, and our average length of stay is about 8 months. I'm so proud of most of our guys end up in long-term sobriety, and so many of them stay and work with us. In fact, my business partner at St. Christopher's is a guy who went through St. Christopher's over 10 years ago. So we're very, very fortunate in our success and our brotherhood that we create out here. And what Madison was talking about at Canyon Crossing is a program that we work with so well. It's very similar to ours, but for women in Arizona. So it's a wonderful program. It does so much stuff for these women, and they are also a long-term program for young women. So it's a good connection that we have in the field that we work with. And Canyon Crossing's program and owners are Aaron and Justin Bachman, who are dear friends of mine who also believe in the power of authentic connection. So in that way, we really fit well today. What I'm going to talk about today is the idea of resistance and noncompliance. I have some objectives that we're going to understand the definition of them. I highlight the differences between the two. We're going to talk about potential behaviors associated with both of these ideas, and then also reflecting primarily on the countertransference that the clinician goes through with the sessions with these patients. So what I'm saying by that is, I know like this presentation used to be called, is this patient a jerk or is it me? And I constantly battle labeling this presentation that, because one, I think it's really catchy and funny, and I like to be super snarky sometimes, but two, it also really takes down the academia type of talk from this to a little easier to understand for us to kind of all relate to this. We all can relate to the idea of resistant and non-compliant patients. That's not the problem. It's the issue of the countertransference. So when I say that we can all relate to the issue of the non-compliant patient, that means like we're all very comfortable at pointing their finger outward. And it's hard when it's like pushed back at us, saying maybe we have something to do with this. So I invite you today to just take a breath, because it's totally you. You totally have something to do with this session. So we'll just go ahead and take that off. You don't have to worry about, no, not me, I'm good, I'm good. No, it's you, babe. And it's me, and it's all of us when we're in sessions. We all have countertransference with these patients, and all patients. And so we're working on that today. Some normalization is, we all experience resistant and non-compliant patients at times, so this is totally normal. We all have feelings, and we are all human and are subject to frustrations and disappointments when working with these patients, so that's also normal. Your feelings, your thoughts, your judgments, totally normal. Oftentimes, however, these patients end up discharged, or they end up leaving AMA, and or they quit and never come back to our private sessions. And this is also very, very normal, but it's absolutely unnecessary. It may not always be the case that you have to refer out, or you have to allow this patient to quit or walk away feeling like it was them, and that doesn't have to be the case. So the goal is to create awareness and interventions for the non-compliant patient. And in doing so, we will explore the root causes of these behaviors and grow as clinicians. So the fair warnings I like to give everybody ahead of time is I am superhuman. My spelling may be off. I'll make a joke here and there. I'll disclose some learning and growth opportunities that I've had with this issue, and I hope that you do as well. I think that it's really fun to share my failures. I find them quite endearing, and I hope that you do as well. I hope that you start to embrace your failures in that way, because that's how we grow as clinicians. So I think that the work that we can do around that, I've done my own work around that. If you're wondering how can you start, it's getting into therapy and doing the work around acceptance of imperfections. I started with the book that Brene Brown had over 10 years ago now. I think The Gifts of Imperfection, that I read while doing an intervention on somebody. And it really was helpful for me to move from this idea of have to be so good in my job, in my life, in my family, in order to deserve anything of good or value. And so now it's moving into the acceptance and embracing really of my imperfections. And by saying imperfections, I also mean failures by the definition that we have as Americans. So it's a formal invitation for you to do this as well. So what is noncompliance? I'm saying this, I'm starting to giggle because we're all working from home and we're all doing this COVID thing. And as I'm talking, of course, I think that there is a giant bug on the window. So it's kind of scaring me. All right, so what is noncompliance? Noncompliance by Arkowitz is one of my favorite definitions, says that he considers resistance or noncompliance in psychotherapy is a reflection of the ambivalence of change. The recent research suggests that the way the therapist responds to this ambivalence may be critical to the treatment outcomes. This is so important because I think when we're trying to think of noncompliance or resistance, we oftentimes think of it as just this commitment to not doing something, to doing the opposite, or avoiding anything that we're recommending. And really, it could very well be Arkowitz's definition of this ambivalence to change. Maybe not this fight against it, but there's just a lack of really commitment for the change. And sometimes that's related to several reasons. It could be due to, hold on, I'm trying to see you guys on this little thing. Okay, nope, that's not it. So that can be due to several things. It could be due to our lack of commitment to the struggle that comes with this change. It could be due to the lack of benefits that come with change, or the resistance of the change itself. So let's get into it a little bit more. Oh, shoot. Now I can't move. Okay, no, I can see. Oh, I can do so many things now. Hold on. Nope. Okay. The non-compliant patient typically evokes a negative response. An example of this would be the woman who's in the nursing home. I don't know if you guys work in some nursing homes. Sometimes they can be very challenging patients in certain ways. And an example similar to the patients that I deal with every day or that you deal with in schools, they could be saying, I refuse to bathe all week, and then she calls the family and complains that she hasn't been given a bath all week. And it oftentimes evokes a negative response from us, that we start to feel yucky when dealing with that patient. There's a yuck feeling, a dislike, a disdain, a lot of judgments that come up. And I know when I say this idea of judgments, that what happens in our brains as clinicians is that we say, no, we don't judge. I'm a blank slate. I have the yellow pad in my hand. I'm above judgment. I never judge. And sometimes when therapists will tell me this, I sponsor and I supervise a lot of young clinicians. Our treatment centers are all learning centers. So we have a lot of young residents, psychotherapists, social workers, counselors, all of that coming through for training. And so often they start their lessons by saying, I don't judge. I never judge. I don't even see color. I don't see color. I don't judge. I'm just not that kind of person. And the truth of it is we actually all do judge. We all judge. We all see color. It's our brain's reaction. Just like what Ted was talking about, his love for the brain. I also have a love for neurological functioning. I love how our brain functions so similarly over and over again. And what happens is we do judge when this patient comes in and they refuse a bath all week and then complain to the family. We have an injury internally to our ego, or our abilities are injured in some way. And then we judge that person as a result of that. So we have a judgment that this is not good, this is yucky, she's not a good patient, those kinds of things. She's difficult, those kinds of things. And then the other picture is when it says my face when a patient signs an AMA. And that can be our own judgment too about this patient has been difficult to work with. I'm not seeing any results. And then sometimes we'll even put a prophecy on that where we'll say, they're never going to get better. They'll always do bad. I know that this was happening so often in my office when I first started working with these patients at St. Christopher's. In fact, it was very, very common for us to go ahead and then label these patients who are resistant or non-compliant in that very beginning with a permanent diagnosis, which we'll get to a little bit later. So noncompliance is often related to a lack of knowledge or a lack of ability. And we're going to break those down a little bit. A lack of effective skills or motivation, or simply no buy-in to the new skill or behavior. Or the new skill or behavior is often less effective immediately than the old skills. So when we talk about that, when we say lack of knowledge or ability, I know that when people were a bit originally talking to me, just lack of knowledge, an example of, or a lack of ability is, in the beginning, when I first started working with a therapist, she told me, well, Brandy, you're an anxious person. And of course I disagreed because I'm a very calm person in my mind. I'm a perfect person in my mind. You can't see my anxiety because I'm smiling so politely and I have a sweet Southern accent and blonde hair. So clearly I'm not anxious. But actually, she was very right. I was very anxious. And when she gave me a skill, she gave me breathing exercises and meditation exercises. There was two issues going on. There was a lack of knowledge and a lack of ability. When she says, do breathing exercises, do you know what I mean by that? And I said, sure, I understand. Deep breaths counting to 10, got it. Or when she said, I want you to meditate, do you know what that means? Yes, definitely, got it. Are you able to do those things? Sure, I am. But in my head, I'm rolling my eyes and I'm judging her as a not effective therapist, of course, because I know better as just a regular person. And I also didn't realize that I had a lack of knowledge. Sometimes you don't know what you don't know. So when I would go home and practice the breathing exercises, I would breathe in my regular breath pattern. I would practice breathing, and my deep breathing was extensive, about like this. Those were my deep breaths. And we know now that that wasn't even rhythmic breathing. It wasn't diaphragmatic breathing. I'm still breathing very shallow, which keeps my heartbeat coherence variance like this. A little rabbit heart is what I'd like to talk about it as, a little anxious rabbit heart. And I didn't even have the knowledge that I wasn't breathing the way that she was talking about breathing. Same happened with my meditation. When she said to meditate, since I know what meditating was, I thought that that equaled ability. It doesn't equal ability. I did not have the ability to sit down and meditate. One, I have a rabbit heart at that time with my anxiety. And two, my knowledge of meditation doesn't equate to ability to meditate. So I didn't realize that I would have to practice and build this skill over time. So what I went and did at home was I practiced my deep breathing. I practiced my meditating by looking at my clock saying, well, that's 2 minutes that I'll never get back in my life. And I went back the next week to tell the therapist that that was completely ineffective. But of course, in my self-pleasing kind of role with the therapist, I said, yes, it was totally helpful. Thank you so much. It worked. I'm all better. And we all can relate to those patients, the one who feels deflated because it's not working, or the one that's also telling us what we want to hear. Those also are the non-compliant patient, the one who doesn't have the ability or the knowledge to do the skill. So sometimes when we're giving a patient something that we know so much about, oftentimes they don't know anything about it, or they know a little bit about it and don't have the ability. We're having to keep that in mind. So when you see your next non-compliant patient, where you're saying, I've given this person a diary card 18 times and they're just not doing it, maybe it is a lack of knowledge or a lack of ability. The next is effective skills for that person, meaning it may not be in their toolbox that they can sit down and do one of these skills that you've given them. When you're a teacher or you're a school counselor and you're working with families and you're saying, I'd like you to go home and spend time with your child bonding. They may think, like last night, my husband was sitting on the sofa on his phone and my two daughters, 11 and 9, were both also sitting on the couch on their iPads. After I had come out of taking a bath, I was like, oh, we're spending family time together on our tablets? No, thank you. Everyone, tablets off. But my husband thought, afterwards, he said, well, why did you interrupt me? I was doing the family thing. And I was like, no, that wasn't the family thing. You were all on your tablets. He said, no, we weren't. I said, I took a picture. You were on your tablets. Here you go. And I showed him the picture. He didn't even realize it. So it's not that he didn't know, he didn't have the ability, it's that he didn't have the awareness, and he also didn't have the motivation at that time to change. He was exhausted from work, the kids were exhausted from school, and they all needed to disconnect and unwind a bit, but they all thought they were doing something different. So that's non-compliance in the same thing, as well as they just didn't have the motivation and skills at that moment. There's also no buy-in to the new skill or behavior, meaning if you ask me to stop smoking, if I'm a smoker, and you ask me to stop smoking, there's really no buy-in to the idea of chewing gum or sucking on a toothpick. It doesn't serve the same as the cigarette did right before that. So we have to try to find what is the buy-in, what's the reason, what's the gift that comes from the new behavior that you're willing to move towards that and away from the old behavior. And that's for all things: dieting, exercise, that's for drug addiction, mental health, moving away from anxious mind into the wise mind. We have to have a buy-in, and we have to be willing to dig that way with a therapist. And also the last one is the new skill or behavior is less effective in the immediacy than the old behavior. When we think about this, I want you to think about every time you've started a diet in your life. If you're like me, started a ton of diets, and I'll eat something healthy. And Madison and I have traveled a lot for work together, speaking around the country, and we'll be like, oh, I ate healthy for breakfast, so I'm gonna treat myself for lunch, because now, since I ate a granola bar and drank some warm tea, I probably am 5 pounds lighter. And I'll be like, oh, look at me, looking good right now. And then I'll get on the scale, and of course nothing has changed. And I've treated myself for no reason, because I've made no effective change in the immediacy. So it means that the diet, of course, takes time, and of course we'll lose weight eventually, but in the immediacy, it doesn't feel that way. It feels like I just ate something that I didn't want, or drank something that I didn't want, and I gave up the things that I did want for no real change. And so what we're trying to give people the gift of delayed gratification. Before we assess that as therapists, you should be assessing that in your sessions. How have they done over time with delayed gratification? How did they do when they were a kid, and how are they doing now? If that's something that's been a problem for them, then expecting them to be compliant with your recommendations and then diagnosing them or pathologizing their non-compliance may not be the best diagnostic skills. You want to try to break down where is the problem coming in, and it could be that their ability to delay gratification in and of itself is blocking them from change. Potential consequences from the non-compliant patient are frustrations from the therapist. Of course, we're frustrated with these patients. We have done so much work in getting out their handouts and worksheets. We have done so much in giving them the books to read and the words to say to their families, and they haven't followed through, or they're failing at these things. So we have judgments, we have resentments, we have prejudices, we have countertransference that comes up in this. For instance, most of the time when I'm dealing with a male who is super judgy and super quick to be the know-it-all in the room, that person will relate to someone else in my mind and my family, and then that countertransference will also come through. Like, I don't like that person. Or a super needy person, and I think I have judgments about being super needy from my childhood. It's not a good idea to be super needy when I was a kid. So now when I see super needy people, there's a judgment that comes up in my brain, and I have to know about that, and I have to acknowledge it in myself in order to be able to move around it as the therapist. Feeling disconnect for the patient. This one is really easy. When people feel yuck, we move away from yuck. When we talk about yum or yuck ideas, when we feel yum, we move towards, and when we feel yuck, we move away. So when the patient is doing anything that brings up any feelings of disgust, yuck, resentment, prejudice, any of those, we're going to push that person away. And it's very, very easy to see this right now, specifically in our country, that we see this such disconnect between the polarization of America. And we're very quick now to push people in the category of the other. And in the other, we're really quick to make judgments and thoughts about those people and never want to be near them again. I see it on Facebook all the time. Unfriend me if you're this, unfriend me if you're that. And so that's really the disconnect that we feel as humans. And we feel it as well for the therapist and for the patient in the room. Pathologizing the presentation of symptoms, that's what we just discussed earlier, which is when we give a diagnosis to some of these things, which may have just been delayed gratification or lack of knowledge or ability or lack of motivation or new buy-in. But really what we end up doing is saying, well, this person is dun dun dun, borderline or narcissist or sociopath, and we just go ahead and label these diagnoses with people because maybe they have been exhibiting these maladaptive behaviors or unhealthy coping mechanisms for their whole life. And we see those unhealthy coping mechanisms as therapists, but we see them as pathological symptoms of personality defects. And so that's what we're really looking for in that. And that's a really dangerous thing that we do that sometimes, and we label a patient something, and it may not be the best way to treat that patient, because then again, that puts them in the other and puts a block for us. So oftentimes this person will quit treatment, AMA, or the therapist will terminate the relationship due to these behaviors, saying these haven't changed over a period of time, I must not be effective for you, let's go ahead and quit this relationship, which leaves the patient feeling judged and at fault. And so sometimes we really need to look at that. Resistance in therapy, I'm trying to go a little bit quick because I know that we don't have too much time. Resistance in therapy is also a negative connotation, but it's indicating an oppositional tendency on the part of the patient. So this means like resistance, just like in the picture of the tug of war. Oftentimes, if you're holding it in and I'm holding it in and I pull, you're going to pull back just out of instinct. That's how our brains work. Similarly, when someone pulls away or pulls, in the direction that you don't want to go, you're going to pull back. And sometimes even unconsciously you will do this. Same in therapy. That's what resistance is. It's the tendency to pull away. It also has a negative connotation. It could be defined as behavior designed to avoid personal feelings of conflict or pain. If you think about that, shouldn't we all have behaviors designed to avoid personal conflict or pain? We're not all leaning into pain every day. I don't say like, ooh, if only I could stub my toe today. I really it's been a while and I would like to do that. No, we do things to avoid stubbing our toes. In fact, I've stubbed my toe so many times lately that now I'm like watching all corners. I make sure that my kids even say, don't step on my toes. I've stubbed them too many times. I don't know why, maybe I'm in a hurry. The thing about avoiding pain is it's a natural reaction, and we want to highlight that and normalize that for our patients. When we're talking to them, we're trying to say like, that makes perfect sense that you wouldn't want to talk about this. Totally makes sense. Or it makes perfect sense that you wouldn't want to open up your vulnerability to your partner when you're really injured, but you show anger. That makes perfect sense. I get that. Let's talk about all the times in your past where you showed anger instead of your injury or your vulnerability. What was so moving to me about Ted's presentation is that he was showing such vulnerability and authenticity. You can see that he's done his work because he's able to very quickly move into authenticity and be connected to people at his own risk, mind you. That takes conscious awareness, and it will take conscious awareness for our patients. Any client behavior or reluctance to the willingness of the interventions that we're offering up could also be shown as resistance. So 5 forms of resistance. The resistance to the recognition of feelings, fantasies, or motives. Sometimes our patients aren't even aware of these motives or fantasies. They're not consciously aware of what they're wanting to do. And sometimes they are, and they're worried about being judged for them. An example I give of this is a young man that I worked with for a period of time. His mother brought him in, and they said, listen, we have this son, we've paid for all this college and education, and he's got all these degrees, but he's refusing to work, and he's just not doing anything with his life. All he does is travel with these fancy women with lots of money, and he lives on their yachts, and they're much older than him, and we have nothing to talk about because he's just being this little playboy all his life. Well, when he comes in, I was like, good, bring him to me. These failure to thrive boys are my kind of boys, so bring him in. And this young man comes in and he's talking, and of course, as a therapist, I have the solutions in my mind. I'm thinking, oh, this thing, I'm going to do so much stuff with him and help him get on the path to college, and to career and family and wife and kids and all the whole shebang. And he'll have a Christmas card going out one day with the updates of the family. But the truth is that he actually had motives, feelings, and fantasies of his own outside of what his mom or even me as the all-knowing therapist would have wanted for him. He had the ideas that, one, this was how he felt connected to people. He loved what he was doing. He felt like he was doing a service for these women. He loved being with older women. He was attracted to older women. He liked being on yachts and fancy lifestyles and flying and jet setting around the world, and he liked being cared for. It was his preference in his relationships. But for me as a therapist, I couldn't even consider that when he was walking in the door. I couldn't consider that that could even be a preference because it wasn't in my mindset. So sometimes it's the ability for us to just sit down and recognize that this person may have feelings, motives, or thoughts, fantasies beyond what we have. He actually we ended up not working on changing his lifestyle. We ended up working on self-acceptance and grace, some forgiveness for the shame he felt that he was causing his family by being his true self. And even with his family, we worked on forgiveness and acceptance of the differences between them and their son, which was very helpful in the end. And I would love to see what their family Christmas letter looks like now, because I'm sure he's living the life. The other part is resistance to revealing feelings towards the therapist. So many times the patient or the client, whichever one you call them, we call them patients over here, which they will have a resistance in revealing their true feelings about us. I know that I was working with a young female who had eating disorders in my early career. And she just would constantly say, yes, ma'am, yes, ma'am. And she had all these thoughts and judgments that she wasn't sharing with me. And they were all about my weight, my appearance, my ability to connect with her based upon my weight or appearance, or my ability to understand or relate to her because of her appearance or her weight. And if she wasn't able to ever tell me that, then we would have gone through these sessions with both pretending, me thinking that I'm connecting to her on a certain way, her thinking in her presentation of self and a fake self that she's doing what I need to be the good patient. And the truth of it is that was not going to be the most effective way to communicate with that patient. The next thing is resistance as a way of demonstrating self-sufficiency. So often the patient is resistant to taking any feedback or guidance because they want to be self-sufficient. Nobody wakes up saying, like, I'd love to be able to not take care of myself at all. Like, I just want to be completely insufficient or ineffective in caring for myself. I'd like to not be able to do one darn thing for myself ever. No, we don't wake up like that. We wake up thinking like, I got this, in some way. In our own brain, we think like, okay, no matter what, I can take care of it. And the way that I think about this is not about a belief in self, like self-esteem or self-worth, that kind of thing. It's just like that you can actually sit in front of someone and not look like in your mind or judgment in your mind of being, I don't want to look like completely stupid or ineffective in front of anyone. That doesn't feel great. So sometimes in the self-sufficiency, in our ability to try to describe or display the self-sufficiency, we'll go along with something and not even know exactly what we're going along with or say what we're going along with. And really it's in front of the person, but behind the scenes, we're going to do what we want to do or do what feels comfortable to us because of that difference or that dissonance that created with that feeling. So the other part is resistance as clients or reluctance to change their behavior. That's just pretty normal. The other one is resistance as a function of failure of empathy on the part of the therapist. So that's really difficult because sometimes the patient can be in a session and not feel the empathy from the therapist, even though we're trying to connect with them empathically. So we're trying to connect with them and that's not working. They're not feeling it. And so on their part, they're resisting under the surface. Maybe on the surface they're complying or they're going along with it, but under the surface they're resisting. And that might look like any of the ones where we're saying, yeah, I think it's going to work out. Don't worry, don't sweat it. It's all going to be okay, when someone's really going through a grief stage. The whole thing of going through something like that and someone saying, oh, it's going to be okay, or there's always a plan, or God's got a plan for you, those kinds of things, that can feel like you're trying to be empathetic to the person or connect with that person in that way, but the person may not be receiving that. So it's really being willing, what Ted was talking about, of sitting in the space with the person. Sometimes the words aren't as important as the connection to decrease the resistance, What does it look like in the patient? Oftentimes the resistant patient is involuntary. They're either talking excessively or they're muted. I've had both. I don't know if you guys who are working in the schools, you've had probably plenty of kids come in there and sit quietly through the session. Overwhelm themselves, they feel overwhelmed. They're overly good patients. That's also the resistant patient. I'm very, very good, so you can't tell me anything. I do all my homework. I brought it in and it still didn't work, so don't blame me. They blame others, denying the help. They're overly dependent on the therapist. This is the one that's like, can I move in? Can I have your phone number? Can I live next door? Can we talk all day long? that's also a resistant patient, because they're resistant in taking self-sufficiency on, they're resistant in taking on the autonomy of self and the work that they have to do becoming independent of the therapist. So even though the therapist may like this patient a little bit better because they're willing to run everything by you, if you're the controlling kind of therapist that I used to be in my early career, you may like this because they're asking you lots of questions, they're wanting your input on lots of things. So it looks like they're trying to make these changes, but it's actually resistant because they're not taking on the autonomy of self. The passive aggressive behaviors of the patient, where they're like, yeah, that was totally worked. That totally worked, except for then my husband left me. So there's the passive aggressive behaviors that they can show, or they're not doing their homework and they're blaming you, or they're not doing their homework and they're saying that this is because of some other reason, but really they just don't want to do it. They don't find value in what you're doing, and so they're not willing to connect. Rely primarily on intellect. This patient can be the very, very smart patient, and they'll come in, the engineers, I love working with engineers and pilots because they have this very mechanistic type of thought process. They're very academic and mechanistic in their thoughts. I like that because I happen to be that type of thought process myself, so I enjoy those kinds of conversations. And so when they'll get onto something like how to fly a plane, I'll be very well, I would go right into that conversation. And then eventually I realized that we've left 10 minutes behind of this session talking about the intellect part of their brain and their job or their interesting thing going on in their life, and we've left behind all this other stuff. So they can often use that intellect to disconnect. And if you're one of those intellect people and you do this from time to time, raise your hand, because I know I have done that too. Like, there's been plenty of times where I'll use that to disconnect and to stay safe rather than lean into pain. Remember when we were talking about that? And then also the ones who use emotion as defense. They'll say, oh, you've triggered me, stop, I don't want to go any further, you've triggered me. That's an emotion as defense statement, saying like, I can't feel anger in here because it's too strong. I can't feel sadness in here because I'll never end. I can't feel grief because I'll start to cry and never stop. All of those things are emotion as defense to the therapist to try to stop the process of the session. Okay. Contributors to resistance are just what you imagine. A history, oh wait, I can't move this over to where I can see this. Hold on a second, guys. Hold on, I almost got it. Okay, got it. History of learned behaviors from managing emotions, meaning this is how I grew up learning things. I always give this example, and I really hope everybody forgives me this cursing one moment of learned behaviors for managing emotions. In my family of origin, there was a family slogan, and it was eat shit and die. I don't know why that was our broken family slogan, but that anytime someone felt lots of emotion in our family, that was shouted from across the room. And it was this, it's kind of like the equivalency of slamming a door. And oftentimes it was linked directly with the slamming of a door. So anytime someone was angry, they would shout that out and they would slam a door, or they would shout that out and they would walk away. And that meant end of conversation. That meant I'm exhausted of you. I hate this conversation. I hate being in this moment. And it was definitely meant for me to flee. It was time to run, and either emotionally, intellectually, or physically run, because that was not a good sign. So learned behaviors for me was when emotions are high, to do something very dramatic to slam it shut. And if you probably have experienced something like that in your life, or you know someone who has. So that's a learned behavior for managing emotion. So a lot of times when a patient will come in, they'll be exhibiting things they learned in their childhood, and they're doing that. And I'll ask, why do you say something so strange like eat shit and die? Why do you say that? And it's because that's what they grew up with, and so that's why they were doing it. I know that when I was young, I did this in college. My roommates would say something silly, and we would all be laughing and cutting up, and I would be like, oh, shut up, I hate you. And it was just something that we said in our household as a way to be funny and also as a way to disconnect. And so when my roommate finally told me, she's like, I really don't like when you say, shut up, I hate you. It hurts my feelings. It makes me think you actually hate me. And I said, oh, I would have never thought of it. They would have never even thought of it. It was just the same as saying hello, good morning to me. So it's learned behaviors that we don't realize sometimes are getting in the way. And if we could find a thread of that we find that needs to be worked on, we can go backwards with the patient with that. Hopelessness is often a contributor, fear of change or fear of success. Self-punishment. Sometimes we feel like we deserve to be at this almost like a whipping post. I hope that's not offensive to say that, but that we almost deserve this beating that we're getting because we've done something that deserves it in our life, that we don't deserve happiness. And that'll get in the way. Or God must be punishing me for some reason. That will get in the way of movement. And sometimes that's behind the resistance. So when we see that resistant patient, it may not be she's just a borderline person or he's just a narcissistic male. It could be that this actually is learned behaviors. They have fear of change. They have self-punishment. They have an issue with perfectionism. Or the other ones, secondary gains, or fear of disclosure, shame, or discomfort. Any of these things could be contributing to what we're seeing in our office. And the danger of pathologizing that as just resistance and labeling it as a personality disorder really is the danger of blunting the work that we're doing. So what does resistance look like in session? Oftentimes, we've gone over this a little bit already. We'll just briefly go through this: arguing, challenging, discounting. The yes, but person, yeah, that worked, but, oh yeah, that might help, but no, oh, I would do that, but, you know, all that kind of thing. The interrupting, talking over, or cutting off. I have so many patient experiences where they're interrupting or cutting me off. Like I've sat there and listened to their same story for the third or fourth time, and I go to give feedback and they cut me off because they're connected to that story. They're fused with that story, and there's a resistance in moving away from that story. Denying, blaming, disagreeing, excusing, all of these things happen. Minimizing, reluctance, unwillingness, claiming impunity, meaning like I didn't do it, it's not my fault kind of thing. I was born this way. Ignoring, inattention, no reply, or sidetracking. These things happen in session a lot with teenagers, a lot with my young guys at St. Chris. This happens, I'm sure, at Canyon Crossing. They have this with the females. It's the same. We do this all the time. We can sidetrack very easily or ignore. Small talk, good behavior, nice. We talked about that. My favorite thing to do is get caught up in small talk and then realize, oh my gosh, I've blown 10, 15 minutes of this session. I need to go round back. The goal for working with these clients in resistance is Messer's goal, which is the hope for resistance. It's really to shift the view of resistance from the negative connotation and problematic to treatment to inevitability and ambiguity, you know what I mean, of resistance, to be greeted as a therapist friend, not enemy. So when we talk about that, it's all this that I've talked about in this whole presentation so far is pulling that resistance in, just like we said earlier about pulling in failure, pulling that resistance or that noncompliance in as the friend to the therapist, not the enemy. It's a gift to the session, not the curse, because then we can go back and revisit. Remember when we sat for 15 minutes last session and small talked? How did you feel at the end of that session? Did you feel we accomplished anything? Wonder why we got into small talk again and again. It seems to me that we bring up small talk every time we talk about the divorce that you're going through with your wife. We then circle back to some small talk, which might be a safety landing pad for you. Let's go back and talk about that. Meaning that small talk is a gift for that session. If we can pull that in and view it as the friend and not the enemy, then we can use it in the session moving forward to connect better with the session, to connect better with the patient. The same can be true for anything that they bring into the session. Anything that they bring, a dislike for you, a judgment about you, a thought against you, disconnect, all of that can be brought in. I wonder what about me is so repulsive to you? Why is it being in this session that brings up this strong feeling of disgust? What is it that I'm doing that's so disgusting in this moment to you? And let's relate that back to your life. Why? Why is that disgusting? So meaning that it doesn't have to be personal about us. In fact, quite often it's about them. When they're talking about their own feelings, it's about them. And so whatever they're getting from our reflection, it's about their own life. So we're using that as a way to find connection to that patient. And our willingness to explore that ourselves is only going to improve the relationship with the session or with the patient. So what he says is it's not the enemy. It is a way in which the client presents themselves to the world in general and to the therapist in particular. So the resistance is how they're exhibiting themselves out in the world. And I always think about this with my patients who've been diagnosed with borderline personality disorder, and they'll come in and they're so wanting to connect, but they're so often giving off the vibes of repelling people away. And sometimes I'll say to them, I know it must be that you want to move closer to this person in your life. You want to be more connected. But what you're saying is, in fact, pushing them further away. When you do these things, you push people away from you, even though your goal is to feel connected. I know that's your goal because you've said that over and over, that you want to be related, you want to be connected, you want to be intimate with people, but you have this issue of people walking away from you, and that must be extremely painful. The reactive counselor response, meaning like our automatic response, we've gone through these: arguing, disagreeing, judging, blaming, pathologizing. We've gone through all of these. You can look through them again. The goal is, because I want to make sure we have time for questions, reframing resistance and noncompliance. Resistance oftentimes is difficulty developing and trusting new patterns of behavior. Noncompliance could be inability to follow treatment plan due to fear or limitations. So the patient who's often relapsed, maybe he left treatment and he had some fear of limitations of how to fit into this group, or how to go to his boss and talk about the need for drug screen monitoring, or how to talk to his boss about need for offer therapy. Or for the resistant one is the difficulty of trusting new patterns or behavior, like I've started this diet, but I don't think that I'm going to be able to finish it, or I've started this behavior diary card and I'm not going to follow through with it, so I'm going to stop right now. There's no way I can do it over and over. Or I tried a change in how I approach my husband and my relationship by talking about what I really want and need instead of just passively aggressively slamming cabinet doors, but it doesn't immediately change, and so I'm not willing to commit to that. So these things, and if we could reframe that in that way, then it makes it much easier. I know as a therapist, whenever someone refers me a patient, sometimes they'll call me up, and now that I've been doing this presentation a lot, people know I like working with resistance and noncompliance. But normally when I call someone up and I say, hey, look, I've got this girl for you. She absolutely refuses to connect with people in session. She blames the therapist over and over. She has multiple failed relationships in her life and inability to stay in employment because of her outbursts and dramatic response to any kind of emotional stimulus. Would you be willing to work with her? Most of the time people are like, click. They're like, nope. If I say, who loves working with borderline personality disorder or narcissistic males, most people are not willing to like jump up to be the first in line for that, because they're viewing it as a resistant or non-compliant patient. But if you viewed it as, instead of the borderline personality, you reviewed it as, listen, she has real conflicting desires to change versus stay with the comfort of the known. Would you be willing to work with someone like that? Or he has a lack of understanding or abilities to follow directives, so I keep giving him this intervention, but his lack of abilities or the willingness to follow this directive has jumped in the way. Would you be willing to work with him? Yeah, sure, no problem. But we take language shortcuts and we say, hey, I had this narcissist who refuses to do anything I tell him to do. You want to work with him? No, of course not. It's important that we reframe these, because then we're able to work with them in a clinical way. Our clinical skill set is to dissect these down, figure out what's going on, and then highlight what we want to change. As therapists, we have tendencies to have reactions to these patients. This is funny because it's when a patient's threatening to leave AMA. This is like every now and then I have this moment when I'm in session with this patient trying to block an AMA, and I'll be like, bye, Felicia, just go. I'm done. Get out. Go. Sign your paper. Get out of here. I'll see you soon. And so but that comes from a situation within the self, right? So we're used to being helpful. We didn't get into this for the money. We're trying to help this person, and how dare they have this behavior. Our goal is for our patients to get better and to come to us saying thank you, and that we've changed their lives, because we're the healers of the broken and lost. We like hearing thank yous. We like hearing that it's been a success. We don't, as humans, we don't want to sit over and over and over for a long time and be unsuccessful or not helpful. We're used to getting fast results as therapists and as humans on the planet. Did you know that most people who are in this field have a tendency to be helpers? We do. We're helpers. We're naturally born helpers. We also have a tendency to be doers. We're the people who like to get things done. Social workers, counselors, psychologists, they tend to be doers. So they're used to getting things done. When that's not working with their patients, their brains have a natural response to that and judgment about that. We're not always good at reflecting on our own part or the relationship or the therapeutic problem. That is the issue. When I hear people come to me with a non-compliant or a resistant patient, oftentimes, and I will watch this, as now that this is like a passion of mine, I will watch the description of the patient, which is all about the patient. Very rarely will they say, listen, I have this resistant patient. Let me start with what I'm doing. What part is mine? I really have a lot of judgments about him when he came in because he was this way or that way. He was a narcissistic male, and I thought, that reminds me of dad, and I don't want to work with those kinds of people. I hate narcissists, those kinds of things. Very rarely does this conversation start that way. But once we have the conversation, it oftentimes will end that way. Yes, I have lots of judgments. Oh, that's true. He's kind of gross to me. I didn't think about it. So if we could then shift our focus to what we're doing and what our part of the relationship is, then we can dissect further what they're doing that pushed our buttons. Because remember, it's presenting to us, but it's also presenting to the world. So what is this about for us? Let's be real here. This is like the space when the patient returns from leaving from AMA yesterday. So we meet again. And I like that face because it's the judgy face we all feel when the patient quits and then comes back and is like, oh, I do need you. Like, okay, I thought so. But we create reasons and justifications for the failure of treatment, and we blame the patient for these. And these are false thoughts. This is not true. This creates safe feeling for our own issues surrounding the lack of progress in treatment and our own countertransference with patients. That's very true. This creates a safety net for us. If we blame the patient, we feel safe. We didn't do it, it's the patient's fault. This, however, does not make truth out of lies. It merely creates a cycle of potential harm for that patient and for the therapist. If we as the therapist continue this pattern, then we also miss so many opportunities to connect in authentic connection. We also miss opportunities to grow and learn of our own issues and our own potential growth areas as therapists. The goal is to create space and interventions that work with this. There's some ideas of creating space. We can use empathetic, I don't know if I'm saying that right. Empathic understanding. I can't, every now and then there's a word that doesn't sound right when I say it. So we can use empathic understanding or empathetic. We can start express non-judgmental understanding, reflective listening. Like, I hear you saying this. I've heard you say this about your mother before, and I'm wondering, why is it that you constantly call your mother a bitch? You continuously say that. You say the bitch when you talk about your mother or your wife, and I'm wondering, what does that mean? Tell me more about it. Because we have a thought when that happens, right? When they say that word about someone, there's a thought that triggers in us, and there's a judgment that's connected to it. But if we could open up in a non-judgmental, as non-judgmental as we can be, curiosity to dig behind that, then we will learn. And the way that we can dig in out of real sincere curiosity is with reflective listening. All of this is to create a space, right? So avoiding the hierarchy dialogue, I think that's really important. I think Reverend Dr. Ted, all of those titles belong to Ted, but he was able to start as just Ted, which helps with that dialogue, with that hierarchy. It helps bring things down and make it more comfortable. If I had heard all of those titles as a patient walking in, I might respond differently to him than if I just hear, this is Ted, I'd like to talk to you. Sometimes I think we get excited about all the letters that we've earned behind our names, but we don't realize that those letters create a hierarchy or a dialogue that comes from that hierarchy in the sessions. ACT has some great techniques to take that away. I find ACT to be very humanistic in its approach. That's acceptance and commitment therapy. If you go in and any of those tools that they have in there are very helpful in creating a safety of an equality almost in the room. We're here to talk to each other. We're here to learn. Encourage process discussions through DBT, meaning moving into the process and not so much the story. That's a very helpful modality from DBT that creates space. Tolerating ambiguity from DBT, meaning we don't need to go in and dissect all these tiny things. We don't need to also go in and question whether or not you said this before he said that, or why he said this and you said that. That's not important. The ambiguity of that is fine. The issue is there was disconnect and there was anger that came up in your relationship with him. Let's talk about the anger and where was that anger and what do you want to move into from anger? So creating that space to talk about that. And the use of appropriate use of self-disclosure that Yalom talks about. If any of you follow Irvin Yalom, he's very open to the idea of self-disclosure. I also am a user of self-disclosure. I think it's very helpful. All of the stuff that I've shared with you and the way that I've talked to you today is very similar to how I'm going to talk to a patient. I'm going to connect with them as a human. I will share with them what's going on. I oftentimes will say, oh, I'm distracted today because I had this and this going on. So let me get a moment to reconnect with you. Tell me what's going on in your day. and then we'll reconnect. Or if they've been having the same resistant behaviors in session, I will say, what is this about? I've seen you do this over and over, and it seems like nothing has changed in that way. Let me go backwards with you and figure out what this is about. Or last session, you seemed to really disengage when I said something about your mother. You know, can you tell me a little bit about what that brought up for you? Maybe I said something that was wrong. Oftentimes creating a space with the use of self-disclosure might be like, I've had so many therapists that I did not connect with, and sometimes I feel like you're not connecting with me, and you may not want to say it. And I want you to give me 3 things that I do that are ineffective in this relationship with us in this room. Tell me 3 things that you think that I could do differently or that are not helpful. So that creates space for them to connect with us. The interventions that we can implement are always the same kind of things: identification and normalization of behaviors. If you're not normalizing constantly in session, then we're missing opportunities. Anytime a patient comes in angry, muted, overly talking, any of those things we can normalize, because it's a humanistic response to discomfort, right? And we've talked about that already. Exploring with the patient reasons or causes of behaviors in a way in which these have been of service, meaning be grateful for these behaviors. The passive aggressiveness, the skills that you have developed, served you well for so many years. It kept you safe from whatever emotion that you're protecting, your vulnerability, your authenticity, your fear of being judged or fear of being rejected. That passive aggressive behavior has protected you all these years, and certainly it's cost you a lot for sure. But there's a reason you've had it, and there's a reason you continue to have it. And so let's be grateful for that, the safety that it's provided us, and let's look at what reason is there to change, and what way do you want to move. So acknowledging those good things that came from that are equally as important before we try to eliminate that behavior. Highlighting ambivalence or ambiguity, talking about that openly, discussing with empathy paradoxical desires to change, and I give plenty of examples about that. I always use self-disclosure in that. I'll always talk about diet, or I'll talk about healthier lifestyle, or even just a commitment to being like, this is not something I would share with patients, but just a commitment to wearing, taking time to put on jewelry every day. And it's just a silly thing, but I always see women who are so put together. They have jewelry on, earrings, necklace match, all of it matches, and I'm like, you know what, I really want to do that. Then I actually don't want to get out of bed earlier and spend more time getting up and putting all that together. And I don't know if I even want to look in my jewelry box. It's a lot of work. So the idea that there's a paradoxical desire to change and the values that are associated with that. And then the other part is practicing patience in the process, meaning giving yourself and the patient lots of grace that it takes time to make any of these things happen. These are some references and resources. Stanley Messer has a good work around this. Vive la Resistance, which is a really funny article. There's plenty that you can see that you can't make me, effective changes. These are all helpful as far as like tools. You're welcome to click on them. You also are welcome to send me any messages or contact me in any way. My contact information, I think, should be on the thing, or it's available through St. Christopher's. My email address is Brandy@Addiction Wellness. You can email me anytime you want. We can talk about it more, or if you want to talk about your own failures, please do so. I'm always open.